course, the longer the stool sits in your colon, the bigger it becomes, the dry it becomes, and then if you're having difficulty passing it, then you're straining, and you just very hard to you get up because you can't pass it, and then it sits there and it becomes even harder and even bigger, and then, so it just becomes that vicious cycle.
Hello and welcome to Cocoa Pods, a podcast of the Birth Center for Natural Deliveries Foundation. My name is Dr. Bola Sogade. I'm a women's health specialist, a board-certified OBGYN, and I talk about all the issues that affect the mom before, during, and after pregnancy, so that I can bring awareness to these issues with hopes to make the problems better. Today, we're fortunate to have with us Dr. Sesi Dosumu Ogunbi. So, Dr. O, now that we've talked to the patient and gotten all the history and all the symptoms, how do we make a diagnosis of lower gastrointestinal bleeding?
Of course, good. Like you said, you have to do a very good, careful history and physical examination. And that's always the very first step your doctor will do to determine, whether what's causing your lower GI bleeding. And of course, the history, like we mentioned, will include, where the bleed, your stool consistency, how much blood you see, whether you're having clots, and then of course the examination, looking at external examination of your rectum, doing a digital rectal examination where your doctor puts a finger to see if there's any mass or hard stool, and then also they can do and also to look for dilated blood vessels. So both blood and the doctors may also want to do some stool studies, particularly if you're having diarrhea, to see if there's any infection like parasite or virus or bacteria infection. There's a test to see which we call a cord blood, to look for hidden blood. Let's say someone comes in with just feeling faint and dizzy. They don't see blood, in their stool, but they're just feeling faint and dizzy. They've lost weight, and you're suspecting that this person has some, maybe anemic, and then the doctor may do the hemocold test, and that's looking for the hidden blood. There are other imaging studies to diagnose lower GI bleeding, depending on what your doctor is suspecting. There's that Meckel's scan, looking for the Meckel's diverticulum. And then also that's basically where they inject a radioactive substance into your body, and it basically lights up in your abdomen. It can detect if that's where the bleeding is coming from. And depending on the clinical history and symptoms, your doctor may also recommend a lower endoscopy, which we call a colonoscopy. And there's looking for polyps, inflammation, where they can get biopsies when they go in to take a look. There's a small bowel video capsule endoscopy, and also useful to find sources of bleeding. So you basically the patient swallows like a small pill-sized camera that moves all the way through your GI tract and takes pictures. And this is look for bleeding in the small bowel, which we usually cannot get to when we do an endoscopy, either from above or from below. So there's that large length of small bowel we can reach. So that capsule endoscopy will help us look for bleeding in those areas.
So basically somebody swallows a capsule, but that is really a camera as prescribed by the doctor,
exactly.
Right? And the camera reaches an area that both the upper GI endoscopy and the lower colonoscopy might not be able to reach.
Correct. You just see as it's going along, it's taking multiple pictures as it's moving along your GI tract. It's taking lots of pictures. So it's kind of interesting when you are trying to review that images after you've completed the source, and usually the patient swallows that capsule and measure like a monitor and then at the end of the study they download all those pictures into a computer, and then the doctor reviews it. It gets a large cup of coffee and reviews and look at all those x-rays and look at all those pictures to see if you can find the source of the because it takes quite hundreds and hundreds of pictures, so you're looking at that really closely. So there are doctors that usually enjoy doing those things, but I don't. It takes a lot of patience looking at those images.
Wow. So where's the camera at the end of the day?
You pass it out. Okay. You pass it out. So of course you want to make sure that the patient doesn't have an obstruction. So because it will eventually pass, you just pass it out in your poop. And it comes out. Yeah.
And then what do? You give it back to your doctor?
No. You just flush it out the pan, just like a poop.
Okay.
Just flush it out.
Okay. So yeah, other diagnostic things that you were talking about.
Well, those are the main ways. And in some cases, in unusual cases, some may want to do things like CT scans or MRI. Again, it really depends on what your doctor is suspecting.
Wow. So
it could be as simple as just like a hemorrhoid or anal fissure. It could be something very serious, as colon cancer or inflammatory bowel disease. So it really depends on what your doctor is suspecting.
Wow. So pregnancy itself can influence the likelihood and the management of lower GI bleeding. Hemorrhoids can develop or worsen due to increased pressure on blood vessels in the pelvic region in pregnancy. Cuts of the anus, anal fissures, and bleeding can develop from hormonal changes of pregnancy, constipation, and the strain of childbirth can contribute to the development of anal fissures and bleeding. And the bleeding could be coming from the vaginal area rather than the rectum anus for obstetric reasons, like if it was from the placenta. But generally, how is lower GI bleeding treated, Dr. O?
Well, treatment of the lower GI tract depends on the cause and the location of the bleeding. Like we said, if the bleeding is very severe, you're losing a lot, your doctor may recommend a blood transfusion, obviously if you lost a lot of blood. If it's just a local tear or hemorrhoid, managed by changing your diet, using stool softeners or using some topical cream to apply. And if it's a polyp that is noted on colonoscopy, they may remove it during the test of the colonoscopy. If it's a bacterial infection, that can be treated with antibiotics. Same thing with parasite, can be treated with medication. And of course, if it's a virus, it usually will resolve on its own.
Wow. Thank you so much. So, we talked about lower GI bleeding. That tells us we probably need to talk about upper GI bleeding. So, the upper gastrointestinal tract, the upper GI tract could have bleeding. And upper GI bleeding can affect individuals of all ages, including young people and pregnant individuals. But the underlying causes and management may differ based on the specific circumstances. So, Dr. O, I want to ask two questions here. What is upper GI bleeding? And what are the signs and the symptoms of upper GI bleeding?
Well, I mentioned the upper GI tract, and as I mentioned while I was talking about lower, is the includes your mouth, your esophagus, which is your food pipe, your stomach, and the first part of the small intestine called the duodenum. So irritation or ulcers in the lining of the upper GI tract can cause upper GI bleeding. So the signs and symptoms of upper GI would really depend on the location and the quantity of the bleeding. It can be obvious and hidden, just like in the lower GI bleeding. If the bleeding is obvious, you'll be vomiting blood, either bright red blood or dark specks of blood that will look like what we call coffee ground, or it could be black. You could have black sticky tarry stools called melena, which look like tar in your stool, and some will come in with abdominal pain with that. So it's like I said, it really depends on the symptoms, and it depends on the location and the quantity of the bleeding. So if the bleeding is eating, the symptoms may, the patient may come in with belly pain. They may feel lightheaded, fainting, chest pain, nausea, difficulty breathing. So your doctor may do a special test on your stool to detect this eating blood.
Wow. Thank you for those answers. Pregnancy itself can sometimes lead to an increased risk of upper GI bleeding due to several factors. Again, hormonal changes of pregnancy, and then increased pressure on the stomach from the growing uterus, which can lead to changes in stomach acid levels, can lead to changes in the integrity of the stomach lining, potentially causing gastritis or gastric ulcers. What is gastritis and gastric ulcer and other causes of GI bleeding?
Okay. Well, upper GI bleeding is a symptom of an underlying problem with the GI tract, which again also will vary with the age. You mentioned one of them being gastritis, but there are some other common causes. It could be just swallowed or injured. If you have an injury in your mouth, or a nosebleed and you swallow the blood, you can throw up some blood. If you have an infection like a fungal bacteria irritation of the upper GI tract, a number of people have heard of something called Helicobacter pylori infection of the stomach that can cause bleeding ulcers in the stomach and the small intestine. Long-standing reflux, or that's a backflow of stomach acid into the esophagus, can present with upper GI bleeding. If you have this repeated vomit, someone is vomiting for whatever reason, maybe in your case, maybe someone pregnant and is vomiting and they're retching a lot, and that can cause like a small bleeding tear in the lining of the lower esophagus, which we call a Mallory-Weiss tear. If you just continue retching, it just causes a little tear, and that can also present with upper GI bleeding. There's certain medications such as the non-steroidal inflammatory drugs like ibuprofen, Advil, aspirin, that can cause irritation and can cause ulcer with the stomach in the lining of the stomach, and that's why they tell you to take it with food. You have abnormal vessels or growth in the esophagus, stomach, and the small intestine. Those are less common causes of bleeding. And then in those that have liver problem, they are at risk of upper GI bleeding due to enlarged blood vessels in the stomach or in the esophagus, which we call varices. And that can really bleed, and that could be quite life-threatening.
Wow, thank you. So how is upper GI bleeding diagnosed?
Well, again, just like with the lower GI bleeding, you want to take a good history and a physical examination. And that's usually the first step your doctor will do. You want to do vital signs. Vital signs are your temperature, your heart rate, your blood pressure, and other vital signs your doctor may want to choose to do. And will help your doctor assess the degree of your GI bleeding. Obviously, if you have a high heart rate, that means your body is trying to compensate for all that bleeding, so those are important information your doctor wants to know. If you have a fever, that may indicate that an infection is possible. And again, we talk about elevated heart rate or low blood pressure, that can be signs of large amount of blood loss. Your doctor may want to run some blood tests. We say CBC to check your level of the hemoglobin, your red blood cells, and they may want to do some lab to check your markers for liver function. We talked about, if you have like liver disease, and it can cause cirrhosis, and then and eventually cause varices. So you want to check your liver function. You also want to check for presence of blood in actually what you're throwing up. Maybe there's a test, and they can check in what you're vomiting, or also in your stool as well. So depending on the clinical history and symptoms, your doctor may recommend doing an upper endoscopy.
Which is, again, taking a camera, this time controlled by the doctor, to look like 360 degrees down the upper GI tract, right?
Yes. We call it, it's a long name, we just say EGD. The E stands for esophagus, the G stands for gastro, and then the D is duodenum, which is the beginning part of the small bowel. So, and then scope to say esophageal gastro duodenoscopy. So obviously it's a mouthful. So we just say EGD, and it basically we take a tube that is connected to the camera. As we're looking at the camera, taking the tube down into your mouth, into your swallowing tube, into the stomach. And in that tube, there are some channels in it. There are channels in it that we can thread in a forceps that opens, and we can get biopsies in all the different areas of the upper GI tract.
Wow. Thank you so much for that. So we talked about hormones like progesterone that can relax the smooth muscles of the gastrointestinal tract in pregnancy, and this can slow down digestion and contribute to conditions like GERD, gastro-osophageal reflux disease. And severe GERD can lead to irritation and bleeding in the esophagus. And then finally, pre-existing conditions like ulcers, called peptic ulcers, can worsen due to the physiological changes of pregnancy. So I want you to say a little bit more about GERD, before you tell us how GI bleeding are treated generally.
Okay, GERD, is GERD. There's GER, which is GER. So GER is gastro-esophageal reflux, and GERD is gastroesophageal reflux disease. We all, let's say we go to a party or a Thanksgiving, we eat a big meal. A lot of us will reflux. We have GERD. That doesn't mean we necessarily have the disease, but because our stomach is too full, body is trying to come out. But when it becomes GERD with a disease, that means it's causing problems, and that problems is that it's causing symptoms like heartburn and vomiting and all of those other symptoms. So gastroesophageal reflux just means food coming from the stomach and it's coming refluxing up into the swallowing tube, which is your food pipe. There's so many causes of that. We have primary and we have secondary causes. The primary cause is where there's dysfunction in the sphincter that connects the esophagus into the stomach. So that sphincter is supposed to stay closed after you eat and the food passes through. But in those that are primary gastroesophageal reflux, that sphincter is not working very well. It's relaxing when it's not supposed to. And of course, when it relaxes, the content of the stomach can come up and go back down. But those that have secondary reflux could be due to anything. If you have an obstruction, if you have hiatal hernia, if you have ulcers, you could have any other things. So secondary causes, the number of secondary causes, we have gallbladder disease, pancreatitis, all those things can cause secondary reflux, but the primary reflux is where that sphincter is not working very well. There are symptoms you can have from that, again, depending on the age, of course, in babies, which we take care of. In babies, all babies will spit up, but we look for worrisome symptoms like are they vomiting or spitting out blood or bile or green, or they losing weight, or they having respiratory. So a lot of kids will spit up or will even throw up, and it peaks at 4 months, or by 12 months they outgrow that. But again, if they're not outgrowing their reflux, or things are getting worse, and they start looking for other causes, So, and then of course in the older kid, or in an adult or young adolescents, then they may present with symptoms like heartburn, regurgitating. Some may even present with difficulty swallowing, which we call dysphagia. They may present with upper abdominal pain. So a lot of symptoms, and some of them may just actually present with a nocturnal cough. They just cough at night, So a lot of them end up going to their pulmonologist or their lung doctor. They're treating them for, asthma, but they're just not responding to that. But they just, that's why it's important to take in a good history. They just say, when I lie down, I just have this, I just cough all night long. A lot of them some of them may do have acid reflux causing their symptoms.
What are the things we can do to prevent, and what are the things that make you have reflux?
Okay, so in a lot, I think a lot of why we see a lot it has to do with our diet. Remember I mentioned about that sphincter that is just not functioning well. There's some things that make that sphincter not even function, even more, that is not functioning well, like the caffeine. Causes abnormal relaxation of that sphincter. Chocolate, peppermint, all those things will make that sphincter relax. If we have a very full stomach, if the stomach is too full, then the stomach just has to has to get someone to come out, So we not eating too much at one time, kind of cutting out, eating smaller meals, and of course obesity as also a risk factor for having reflux as well.
Well, and the sphincter, is that like a gate? Can you explain that to us in layman's terms?
Yeah, it's called the name is lower esophageal sphincter. You could call it a gate, It's like, yes, exactly. That I think I've actually heard of people use that word before, but I think that will make sense. That would explain in a lower time. So it's like a muscle that, when you eat, it just relaxes to allow food to pass into your stomach, and then it closes back up. So it's a gate. It closes back up. So keep the content of the stomach from coming up. So yes, that's what I would call it.
Wow.
The lower esophageal sphincter.
Wow, thank you. And then, so how do we treat this generally?
Well, treating reflux, and we could talk more about treating upper GI bleeding. But treating reflux, again, we make some diet changes. Again, telling the patients to eat small meals, not eating 2 or 3 hours before bedtime. If you have a full stomach, you go lie down. There's more chance for it to come up. Avoiding food that trigger food, like we talked about caffeine, chocolate, peppermint, spicy food. All those things can make your reflux worse. And then, if if someone is overweight, you want to try them to get to a healthy weight, as well. Avoiding exposure to tobacco smoke. Tobacco smoke has also been shown to affect that lower esophageal sphincter.
And then stress,
Well, stress will make your symptoms. Again, a lot of people that are stressed, not eating well, they're maybe just their health, the diet, and then that's and you tend to feel it more. I think it's more of you perceive it more, which I do, but not that it necessarily causes it, but it will make you feel it more because of your lifestyle, because you're going through a very stressful period of in your period. So yes.
And then for the treatment of upper GI bleeding, how can we treat this condition?
So your doctor's treatment plan will depend on what the suspected cause of the upper GI bleeding is. So depending on the degree of the bleeding, and the vital signs and the hemoglobin, your doctor may decide to do a blood transfusion. Obviously, if your heart rate is high, your low blood pressure, you have a low hemoglobin, they may want to transfuse you. And if there's an infection, is the cause, they may provide some antibiotics or antifungal medication can be prescribed. If it's reflux, your doctor will provide some anti-reflux medication in addition to those lifestyle modification, or what we call reflux modification. This medication will prevent the reflux from happening or making your stomach juice less acidic so that it doesn't cause more irritation to your esophagus lining and allow it to heal. So during the upper endoscopy, your gastroenterologist can use several methods to stop active bleeding. There's some people that have active bleeding ulcers, and that they may inject some special medication or apply heat or to the site of the bleeding, or placing like a metal clip to the bleeding ulcer to use to stop it, or they may use band if there's an enlarged, like if someone comes with viruses, they may band those viruses to keep it from bleeding.
Wow. Thank you for that. So it's important to note that if someone experiences symptoms of vomiting blood, dark or tarry stools, abdominal pain, or symptoms of anemia like weakness, they should seek medical attention promptly. Pregnant individuals should receive appropriate prenatal care and communicate any unusual symptoms to their healthcare providers as soon as they can. So, Dr. O, I want to ask you two questions. And it's about constipation and hemorrhoids. So why are pregnant individuals a little bit more prone to develop hemorrhoids and constipation? Can you just tell us some things about these two things that are fairly common?
Well, I would, because I take care of children. So, but my suspicion is that it has to do with the hormone imbalance. There's a lot of those hormones can affect the motility of your GI tract, and of course, when it affects, it slows things down, and that can cause constipation. So basically, dysmotility, slow motility of your GI tract. And by the way, pregnant women are also at risk for having reflux because you have that baby pushing on your diaphragm. And so a lot of pregnant women can tend to have reflux during pregnancy. They can have reflux during pregnancy. But going back to your constipation, yes, they can, be constipated because slow motility. And of course, the longer the stool sits in your colon, the bigger it becomes, the drier it becomes, and then if you're having difficulty passing it, then you're straining, and you just very hard to. You just come out and you just you get up because you can't pass it, and then it sits there and it becomes even harder and even bigger, and then, so it just becomes that vicious cycle. So some of them, some may just respond to just making some diet changes, may eat more fiber in the diet, but some may need to be on some medication to kind of help soften the stool so it's easier for them to pass.
Wow. So for constipation, how can we prevent, just anybody, what are the things that we should do so we don't get constipation very frequently?
Yeah. So constipation, of course, we want to improve our diet, and that includes eating food with fiber. That will include things like vegetables, vegetables and fruits and beans has a lot of fiber in it. So they usually say you need about 25 to 30 grams of fiber. Adults need 25 to 30 grams of fiber a day. Daily. You obviously could eat more than that, but the more fiber you eat, the better Basically what fiber does is it draws water into your colon and keeps your stool soft, so it's easy for you to pass. So pregnant women may want to eat more fiber, more food, and which is also better for the baby, I'm sure.
Yeah, and then hydration.
Hydration, of course, and plenty of hydration, drinking plenty of water as well, certainly.
Wow. And then for the hemorrhoids.
So for the hemorrhoids, obviously, of course, the main thing is to prevent the hemorrhoid from forming, and that's treating the constipation. So because the reason why you're having hemorrhoids is because you're straining, you're putting so much pressure on that dilated blood vessel. So if your stools are soft, then you don't have to strain. So they're not. That's a way of healing it. So of course, hemorrhoids could be painful, could get irritated or it could bleed. So again, after you treat your constipation, there's some topical creams you can apply to that to that area. Very, very rarely do they have to do surgery. And not many people are doing that now. So just treating the underlying cause, and then just topical is usually plenty for most people.
Thank you. So, yeah, thank you for that. So, we just want to pivot into your day-to-day activities. So Dr. O, can you paint us a picture of your day-to-day activities and just tell us a fun item about you, because we've been talking about stools and constipation all day.
Okay. All right. Well, I'm a very routine person. I like to review. So if I'm off my routine, I kind of gets me. As I would say, this stuff my wow. So it's I usually try to wake up early in the morning. I tend to wake up around 5, and I do my devotion and pray, and then I go to exercise. It depends on where I am. I may go out, if there's a place I can go running, I go out running. And by the way, I love running. That's my pastime. I like to run. I run marathons. So that's one of my it's a kind of a stress reliever for me. So I like to do that.
Can you tell us how many marathons have you been involved in your life?
I know you were going to ask me that question. I knew you were going to. Yes, I've done 57 marathons, and I keep setting these goals for myself. And by the way, I started running marathons when I turned 50. And so I had a goal that I was just going to run. My goal was to run 50 marathons in my 50s. But when I did 50, and I said, I'm going to when I'm almost going 60, let me just do 60. That's my next goal. And then so I keep pushing it. So I keep setting, like I said, I like setting goals for myself. So my next goal is to do 60 before I turn 60. So yes, so I've done 57 so far. So I have 3 more to go to get to that goal. And that may change too. I may have another goal. I may push it another 70 marathons. I don't know. We'll see. We'll just see. Yeah. And so I like to have routine, and I go to if I can run or do exercises. And then of course I've had the pleasure of spending some time with Dr. Sogade. We did some weightlifting, which is my first time doing some weightlifting. I've never done weightlifting, and some spinning. So that was fun. That's fun. So they always say you should cross train when you are, if you're running, you should also do other things. So that was interesting. I think I will do that. I'll keep doing that. And then I go to work and try to eat meals, set good examples, and go about my day.
Wow. So I know we talked about an item outside of. Is there another item outside of your area of specialization other than having ran 57 marathons in a very short period of time?
Oh, well, I believe we all need to have a life purpose. That's why do we exist? So the Japanese call it Ikigai. Ikigai is spelled Ikigai. This is what drives you. What's your Ikigai? So if you want to lead a life of success, a life of complete success, happiness, and fulfillment, you must have your life purpose. You must have your Ikigai. So if you don't know what your purpose, or if you don't know what drives you, what inspires you, you then have no reason to improve your life. So you have to have a purpose. If that helps you to say, okay, what do I need to improve? What's my life purpose? I tell you, in life, time and time again, you will be tired. You have a why if you give, you just have, there's so many things that brings us down that can upset us in life. But if you have that drive, that your Ikigai, if you have a life purpose, it gives you that extra foot that you need, that extra hour that you need, that courage to keep you going. We need to find something that drives you. So no matter what happens, this part of you can change. And this purpose never dies, no matter how many times life knocks you down. You just keep moving on.
Wow.
That's your Ikigai. You have to have your Ikigai, your life purpose.
Wow.
All right. Well, I believe we all need to have a life purpose. Why do we exist? The Japanese call it Ikigai. That's Ikigai. This is what drives you. If you want to live a life of success, a life of complete success, happiness and fulfillment, you must find your life purpose. You must find your Ikigai. If you don't know what your purpose is, if you don't know what drives you, what inspires you, then you have no reason to improve your life. So I tell you, in life, time and time again, you will be tired. If you have a why, it will give you that extra strength, that extra foot you need, that extra hour you need, that courage to keep you going. We need to find something that drives you no matter what happens. This part of you does not change, because your life will knock you down. You have all you'll be in the valley, but if there's something that drives you, it just keeps you going. That purpose, it never dies. So no matter how many times life knocks you down, your purpose pulls you up every time. So we all have to have an Ikigai, a life purpose.
Wow. Dr. Sesi Dosumu Ogunbi, we are very grateful to you and very fortunate that you were able to come to Cocoa Pods podcast. And again, I would just like to extend my most grand appreciation for your willingness to participate and all the knowledge that you have imparted in Cocoa Pod podcast, a podcast that we believe can make change. Thank you so much for coming.
All right. I've had so much fun. Yes, I can now say, put it on my checklist. I've done a podcast. Thanks for inviting me, Dr. Sogade.
Thank you.
It's been fun. Thank you.